All right. Thank you all so much for joining us today. My name is Patrice Lindsay. I will be your moderator, and welcome to our um, webinar during Stroke Month. Happy Stroke Month, everybody. It's been a great start to the month. At Heart and Stroke, our focus has been on FAST and on, response to FAST and stroke care, and we've had great attention and raising awareness. So that's been awesome. And huge thank you to everybody joining us today. You're all very active members of our stroke community and do so much every day for people with stroke and to raise awareness. And we're incredibly grateful to all of you. So today's webinar is going to be focusing on our new stroke best practice module on cerebral venous thrombosis. And just before we start, I'm going to do a couple housekeeping things. So we are sharing, as you've all joined, on Zoom today. So for Zoom, if you have any questions, please make sure your volume's high enough so you can hear everybody. If you're having any trouble or challenges, please go into the Zoom support and they will help you. We do have if you look at the bottom of your screen, there's a question and answer, a Q&A section. Please post your questions as they come up throughout the webinar, and then we will address as many of those as we can at the end. We leave time at the end for questions, and we really appreciate hearing from the audience. What's on your mind? What are your thoughts? What do you want to know? So please make sure to throughout be adding those questions. We are recording this webinar and it will be posted usually within a week or so on our website. And for those of you who missed part of it or are bilingual or French speaking, there will be a French version of the webinar being held next week. So you get to hear it all over again next week in French if you're interested. So that's all of our housekeeping. Let's start our session today by really thinking about the land and acknowledging the land we're on. Today, we'd like to acknowledge all the Indigenous peoples of all the lands that we're on today. While we're meeting virtually, you're all coast to coast at the moment. And it's important that we think about the land which we each call home. From coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, the Métis, and the First Nations people that called these lands home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. We're gathered today because of a shared commitment to equity, including health equity and reconciliation. I encourage you to take a minute to reflect on the land that you're currently working on, living on, and enjoying for all your social and leisure activities, and really appreciate what we've been giving and this wonderful place we call home. Thank you. So today, as I said, our focus is going to be on cerebral venous thrombosis, both the science and where the current state of the science is at. And there's been major advances in the science over the last while, and our speakers have been some of the leaders of that, as well as looking at how we've then taken that science and integrated it into a brand new stroke best practice guideline. So we're going to explore the epidemiology, risk factors, presentation, and really the practical clinical side of what do you do with this person in front of you, as well as looking at the current evidence and what you're going to find in the best practices. We're really going to hear from a person with lived experience, what it's like to be a person experiencing cerebral venous thrombosis, what wonderful tips Aviva can give us as health professionals to keep in mind as we're caring for people with this condition. And then just at the end, we'll highlight some resources and supports that you can turn to. So I'm very honored today to share with you and introduce you to our three speakers. So our three panelists today starts with Dr. Thalia Field. Thalia and Dr. Jennifer Mandzia are co-chairs of the Cerebral Venous Thrombosis writing group for stroke best practices. Thalia is one of our global leaders in the space, so we couldn't have had a better person presenting. She's really been at the forefront of a lot of this research. She's a stroke neurologist and clinician researcher at the University of British Columbia in Vancouver. And she's an associate professor and holds the Saunders Family and Heart and Stroke Professorship of Stroke Research. Our second co-chair is Dr. Jennifer Mandzia. Jennifer is also a stroke neurologist and associate professor, and she's in the Department of Clinical Neurosciences at Western University. which when I went there was the University of Western Ontario. So I'm still not used to the name change. She is also the medical director of the Southwest Ontario Stroke Program and London Health Sciences Centre Stroke Program. We're very, very honored today to also have with us Aviva. Aviva has experienced cerebral venous thrombosis in 2019 at the age of 27. And as you'll learn today, that CVT is particularly prevalent among younger women. And we're going to hear more of her story about the time she spent in hospital and rehabilitation in Vancouver. And this experience and her recovery led to a change in her career. She currently lives in Burnaby with her wife and is a proud owner of a dog and cat. In her spare time, she enjoys running, trail running, cooking, and traveling. And she works as a registered dietitian and is very passionate about health and promotion. And we're so very grateful for her joining us today. There are no conflicts. Aviva and Dr. Mandzia have no conflicts to declare. And you can see Dr. Fields mainly in the field of the research that she works in this area and has had several funded studies. It's now my honor to turn this presentation over to Dr. Jennifer Mandzia to start our presentation. Thank you, Jennifer.
So thank you, Patty, and I'm excited to share with you some of the highlights of our new and first Canadian guidelines. So why is it the right time for new guidelines? Well, the epidemiology is changing with better ascertainment with the use of vascular neuroimaging. So perhaps there is a changing demographic profile, which I will talk about. And as Patty highlighted, this is still a disease that does affect more commonly young women than men. So emerging data, we now have studies on the use of direct oral anticoagulant. And we have a national Canadian study, which Thalia was the PI for, informing patterns of practice, diagnosis, and outcomes after CVT. And one of the very unique parts of this study was new prospective data on patient-centered outcomes. And I think one of the strengths of our guidelines is that we do focus on the perspective of people who have experienced and lived with a CVT. So this is just a snapshot of the sort of table of contents that I'm not going to spend time on today. So what is a CVT? And we chose a broad definition. So as opposed to more specific alternatives such as cerebral venous sinus thrombosis, we wanted to define it as thrombosis of the veins of the brain, which can include the dural venous sinuses, but also the cortical or deep veins. And what's excluded is we are not going to, our definition does not include extracranial or end organ thromboses like retinal vein occlusion or jugular vein thrombosis without intracranial extension. So overall, this is still a rare cause of stroke. It accounts for about 0.5 to 1% of stroke. And with, as I said, the use of vascular neuroimaging, we are finding that there is a higher CVT incidence than previously. So it's still less common than DVT. You can see it's about 10 to 15 per a million per year. And that, as Patty was saying, the prevalence is definitely higher in women, which we've known for a while. So it would be 3 to 1 female to male, and it's very common in young women of childbearing age. So 80% do occur in women under 55, and there is a strong association, which I will talk about, with estrogen-containing oral contraception in the postpartum period. Luckily, many people who do experience still do have a very good functional prognosis in about 85 to 90%. So in terms of the graphs on the right side, the first graph is administrative data from the United States, just showing that over time between 2005 and 2017, that there is an increase in the rate of CVT. And the women, in terms of the rate in younger women, that sort of stayed constant, but we have seen that men are sort of being diagnosed more frequently with it, and perhaps more older women. And that may be due to ascertainment and perhaps cancer survivors that are surviving longer. And then this is just another snapshot, still showing you that, typically it is much more common in women. But you do see these, that they're, they still can affect older individuals. And likely this is related to, over time, we're scanning people more and we're finding this more and we're more aware of the diagnosis. sorry. So how do patients with clinical present? So sorry, I just want to make sure I skipped one. So this is just a schematic that we created showing patient characteristics, risk factors, and conditions based on, meta-analyses and studies that have looked at this. And just to highlight, as I said, it's much more common in female and younger females than males. And the most common are, oral contraceptives, pregnancy, hereditary thrombophilia, and then there's less common causes that can cause CVT. So most patients with CVT typically present more insidiously than other forms of stroke, but patients can sometimes present with acute symptoms depending on how the CVT is affecting their brain. And thunderclap headache can be one of the presentation, but often it's not acute in onset. And a lot of patients don't necessarily present to medical attention right away. So less than 50% of patients present to medical attention in less than 48 hours of symptom onset. Acute CVT is a potential medical emergency. And this is a Canadian study through the Secret study that just showed that 40% of people with CVT presented to medical attention more than once prior to diagnosis. And repeat presentations are much more common in women, you can see here, versus males. So this just tells you about the pathophysiology and the varied presentation. So, patient has a cortical and a sinus vein thrombosis. This causes increased pressure in the venulary capillary system, leading to decreased cerebral perfusion pressure. Then this can lead to blood barrier disruption, decreased cerebral perfusion. You can get cytotoxic anemia, which can lead to hemorrhagic infarction and parenchymal hemorrhage. And that will influence how a patient may present depending on where they are in this pathophysiology spectrum. So what are the most common features? So headache is definitely the most common. So this is based on, the two largest published prospective studies. So headache is probably the most common, followed by seizures, and then focal neurologic deficits. Patients can present severely with decreased level of consciousness and encephalopathy, so always something to consider. Visual loss is another presentation in about 13 to 27% of patients, and then other cranial neuropathies, including diplopia. So we want to stress the importance of awareness by healthcare professionals. As you could see that, patients may have come to medical attention on several occasions without having this diagnosis. So we want healthcare professionals to be educated in CVT and receive the appropriate education. And also really important that, when a emerge doc or family doc sees a patient, that they consider the patient's individual symptoms and their risk factors, which can help you consider this diagnosis and put it on your differential. So this is just a snapshot of the many imaging presentations of individuals that have had CVT. These are snapshots of patients that I have seen who have presented with thrombosis in their jugular veins, in their sigmoid sinus, as a cortical vein thrombosis, in the superior sagittal sinus, and even a very, very dramatic presentation of bilateral intracranial hemorrhage. So in terms of imaging, just for the sake of time, this is the recommendations, and it's based on sort of limited evidence out there in terms of comparing these different techniques. But any patient who is diagnosed with a CVT, we strongly recommend that they get both parenchymal and neurovascular imaging. A non-contrast CT is not sufficient, so they either need a non-contrast CT or CT venography, or an MRI of the brain and MRI venography. And anybody who is suspected of having this diagnosis should either undergo, as I said, contrast-enhanced CT venography or contrast-enhanced MR venography. So time of flight is not good enough with MRI, as it can lead to possible false positive diagnoses due to flow-related artifacts. And then in terms of if you are suspicious of a cortical vein thrombosis, CTV sometimes is not as good to see these little cortical vein thrombosis. We would also recommend an MR gradient echo or susceptibility weighted imaging. So this is just laboratory investigations. Thalia is going to talk more about the hypercoagulable part, but this is just some of the standard things that we would recommend when seeing some, and I'll defer to Thalia to talk more about this thrombophilia screening. So just to end off my part, one of the things that we really want to highlight in our guidelines is the threat of visual loss in CVT and the importance of diagnosing this. So in the VENOS study, approximately 26.5%, so about a quarter of the patients were presenting with visual changes. In terms of the data, we don't have amazing data in terms of how many patients actually have papilledema, because it hasn't been tracked systematically, but I would say about 32 to 48% based on series. And then what does a patient with papilledema, what does an individual who has this present? So as you would know, blurry vision, diplopia, photophobia, possibly visual obscurations, it's usually bilateral. And why is this important? If it is not diagnosed quickly, it can lead to severe and permanent visual loss. And just to point out that we don't really understand this, but later onset papilledema can occur in rare cases of CVT. We don't really know exactly why, but it could include possibly lack of recanalization of the sinus, residual venous sinus stenosis, and then some of the shared risk factors we know for idiopathic intracranial hypertension. So our recommendations is one of the things we stress in our new guidelines is the importance of having partnership with our ophthalmology as well as optometrists to help us make this diagnosis. So, any individual who presents with visual symptoms or increased intracranial pressure on bedside exam, so use that fundoscopy, needs an urgent ophthalmologic assessment, ideally within 24 hours to 48 hours. And this is a strong recommendation. Again, the quality of the evidence is not there, but we feel strongly about this. In terms of clinical considerations, we feel that all individuals with a new diagnosis of the CVT should have a full ophthalmologic assessment, and this is what is included in a full ophthalmologic assessment. And then anybody who has visual abnormalities or severe papilledema, of course, should receive the urgent ophthalmology assessment, and the treatment of choice is acetazolamide, which is based on the IIH trials. And patients who don't have visual symptoms or signs of increased ICP, we still feel it's important that they should have an assessment within 7 days. And if patients have no ophthalmologic abnormalities, we still would advocate that they, down the road, because of this possibility of a late presentation of papilledema, that they have a subsequent ophthalmologic assessment. Now I'll let Thalia continue with the presentation.
Thanks so much, Jen. So when we see patients presenting acutely with cerebral venous thrombosis, we have to think about the principles of management. And primarily these include treating the hypercoagulable state systemically in addition to the clot in the head. Anticoagulation will facilitate recanalization of the clot in addition to preventing further extension and parenchymal damage, as well as supportive care for all of the factors that can be involved when people present with cerebral venous thrombosis related to increased intracranial pressure, seizures in about a third, a lot of pain related to the headaches from increased intracranial pressure, as well as treating and removing any reversible precipitants. So that's reflected in these recommendations. And of course, we know that in general, patients who are treated on stroke units get better care, as well as access to dedicated allied health services. So next, just moving ahead, just talking about anticoagulation in stages, we can think of it in terms of principles with initial management, usually with parenteral agents like unfractionated or low molecular weight heparin, before we move into the transition to oral anticoagulation for primary treatment. And then there's a decision point about whether or not to consider anticoagulation over the longer term for what we call secondary prevention of recurrent venous thromboembolic events. So there have been a few studies comparing use of low molecular weight heparin to unfractionated heparin as the initial parenteral agent. What I would say in general is that these studies are either underpowered because of the rarity of cerebral venous thrombosis as randomized trials, or there are observational studies that can be confounded by indication. But in general, we recommend low molecular weight heparin as the preferred agent for initial anticoagulation. It has more predictable pharmacokinetics and a more reliable anticoagulant effect than unfractionated heparin, and is also associated with a lower risk of heparinous, HIT. And with unfractionated heparin, those patients that you're going to consider for use of unfractionated heparin, of course, are patients with reduced renal function where low molecular weight heparin is contraindicated. And in addition, those few patients where there may be an anticipated procedure like a decompressive hemicraniectomy or a lumbar puncture, where the anticoagulant effect is going to need to be reversed very quickly. So in addition to considerations around what you use for initial anticoagulation, I would also remind people that the presence of intracranial hemorrhage in the context of cerebral venous thrombosis, unlike other types of hemorrhage, is not a contraindication to using anticoagulation off the bat. The impetus for bleeding is different in cerebral venous thrombosis. You have parenchymal damage due to increased hydrostatic pressure from reduced draining in the venous system. And if you treat with anticoagulation, that clot reduces in size and recanalizes. And so the impetus for the bleeding goes away. So it's a different mechanism. And it's important because more than a third of patients will have some degree of bleeding on their scans at baseline. These are pictures on the right-hand side just from a series of different types of hemorrhages that you can see with intracranial bleeding related to cerebral venous thrombosis. The other thing I would say is, if you're nervous, we always have the option of doing follow-up scans to guide us if, you do feel like it might be possible or needed to take a pause with anticoagulation. With regards to using DOACs as the initial agent, I just want to point out that kind of the evidence for DOACs is mainly related to this primary anticoagulation stage as opposed to right off the bat for initial management. There have been a few main studies looking at DOACs for cerebral venous thrombosis and comparing them to warfarin. Respect CVT, which compared warfarin to dabigatran, and the pediatric Einstein Jr. trial, which compared rivaroxaban to standard of care, either with warfarin or continuing low molecular weight heparin, had by requirement at least a 5-day lead-in with use of unfractionated or low molecular weight heparin prior to transitioning to oral agents. In the Canadian SECRET trial, we didn't have a prerequisite for lead-in anticoagulation. And I just want to point out that there's really nothing magical about that 5-day lead-in. A lot of patients were randomized and given oral anticoagulation prior to that 5-day window. And we didn't see any early safety concerns related to bleeding or clot extension in that early period. In the ACTION CVT study, which is a large retrospective study of people that got either warfarin or DOAC as part of their routine clinical care, more than 60% of those patients started their DOACs before 5 days. In terms of extensive research, however, in terms of timing of anticoagulation, the research is not yet there in terms of this rare disease. There are patients where we do start people initially on DOACs as compared to having this lead-in period of initial anticoagulation. This is a case-by-case decision-making that you make with experts in hematology as well as stroke. And what I would say is the typical patient where we would start DOACs off the bat in, these are very well patients who are able to go home and they're able to reliably follow up in the outpatient setting within the next couple of days with repeat clinical and neuroimaging assessments. These aren't the sort of patients who require admission and observation on a stroke unit, and often they won't have any parenchymal changes on their scans. But again, this is kind of a judgment call made by experts. With respect to endovascular management, we know it's transformed the treatment of acute ischemic stroke, but its role in the routine treatment of cerebral venous thrombosis, again, is not there. And we do not recommend endovascular therapy as a routine thing that you would do in the context of an acute presentation of cerebral venous thrombosis. We do acknowledge that there are patients who continue to deteriorate even in the presence of anticoagulation, and certainly for use as a rescue therapy, endovascular therapy is appropriate in people who are deteriorating and you don't have other options. But what I would say with endovascular therapy is that we really don't know who the ideal patients are, what the ideal technical approaches are, what the ideal timing is. And the one clinical trial where they did look at endovascular therapy as a routine thing to do did not show a benefit. So the 2-ACT trial, which was testing endovascular therapy for cerebral venous thrombosis, made an attempt to enrich patients who had worse prognostic features. So people who had presented with decreased level of consciousness, or people who had blood on their scans, were randomized to receiving best medical therapy versus endovascular therapy. And in terms of what they were doing, it was kind of whatever the practice was at that center in terms of approaches. The primary outcome was a modified Rankin scale score of 0 to 1, so little to no limitations to previous activities at 12 months. The trial was halted early for futility after about a quarter of patients had been randomized, and you can see the numbers are very small, just over 30 in the endovascular group and the standard care group. There were no differences in rates of the primary outcome at 12 months. And if you're tempted to kind of look at trends and differences of the MRS of 0, I would just remind you again how small these groups are. And the other thing is that endovascular therapy was not free of complications. About 10% of patients who received endovascular therapy had sinus perforation. So, again, while this is something that we can consider as a rescue therapy, as a routine thing that we do for treatment, it is not ready for prime time. This is unpublished data. We actually did a survey of practices around endovascular therapy internationally. And, there are subsets of patients who are being treated with endovascular therapy, again, primarily as a rescue therapy. But basically what I want to show you on the left is just the techniques and approaches that people are doing are completely all over the place, which I just think speaks to the equipoise as to what we should actually be doing if we do endovascular therapy in patients. And same thing about the factors related to clinical decision-making, either clinical factors or radiographic factors. I think we really need some clarification before this is ruled out as a larger treatment for cerebral venous thrombosis. So, the recommendations, as the way we've written them, stress the use of endovascular therapy as a rescue therapy where there's clinical deterioration despite best therapy. In rare cases, again, decisions made by expert stroke neurologists and experienced neurointerventionalists. There may be a few cases where it's deemed appropriate to go in as first line, but these are rare cases. And again, the call is made by experts. And we also stress the importance of experienced neurointerventionalists because, again, there's no standardized technique for endovascular therapy. And the other thing, too, is just because you've opened the sinus doesn't mean that you don't have to treat the overall systemic hypercoagulable state. And there's also a risk of this venous sinus reoccluding. So these patients need to go on anticoagulation as well. Hemicraniectomy in the context of cerebral venous thrombosis, just like it is for ischemic stroke, is a life-saving measure. And it's to be used in patients who have malignant increased intracranial pressure and whose lives are threatened. This is just an example of a patient of mine who presented with depressed level of consciousness, who received a decompressive hemicraniectomy. And the other thing I think that just is important to show is that the natural history of these venous infarcts, this is someone who received a decompressive hemicraniectomy, eventually the nature of the tissue damage is different than what we would expect in acute ischemic stroke. And this is important in considering outcomes in what we know from prospective studies of patients who received decompressive hemicraniectomy for cerebral venous thrombosis. This is the largest prospective series, the Decompress 2 registry, and the results have just been published very recently. Not surprisingly, it's patients that have worse clinical presentations with one or both fixed pupils and depressed level of consciousness who have worse outcomes. Patients who are older, which we know in general for cerebral venous thrombosis, have worse outcomes. And interestingly, patients who had hematoma evacuation alongside the hemicraniectomy also had worse outcomes. And again, I think that's because, some of this tissue may be viable based on what we see with longer-term imaging. In general, however, the types of patients that get hemicraniectomy have worse outcomes than your average patient with cerebral venous thrombosis. We know that about 90% of patients have an excellent functional outcome following cerebral venous thrombosis, whereas patients who receive hemicraniectomy, that's the case in less than 2/3. So just moving on to primary anticoagulation as we transition to oral anticoagulation, there have been a lot of studies, as I've kind of hinted previously, that have looked at comparing DOACs to vitamin K antagonists for cerebral venous thrombosis. You know, I want to stress that because of the nature of cerebral venous thrombosis as a rare disease, these studies are small. So we're looking at general trends with regards to any safety concerns with one treatment versus another, and trends towards efficacy. What I would point out is that in the studies overall, the rates of complications were low, both in the vitamin K antagonist warfarin arm, as well as in the DOAC arm. And overall, rates of recanalization were similar between agents, and rates of VTE recurrence overall were low. For kind of patients in general who are well, who are awake, who are ready to be transitioned to oral anticoagulation and who can swallow, it does appear based on the existing evidence that DOACs are a reasonable alternative to vitamin K antagonists. This has also been kind of demonstrated in a bigger population in the retrospective observational action CVT study. Again, it's kind of bigger than all the other clinical trials, but it's just a retrospective registry of people who received DOAC as part of their routine clinical care. In Action CVT, there was actually an advantage of using DOACs with a slightly lower risk of increased intracranial hemorrhage in patients who were on DOAC as compared to warfarin. But overall, other rates of issues like VTE recurrence, rates of recanalization, mortality were similar between the two groups. And these were similar results that were also found in meta-analysis data. So groups that I want to stress are not appropriate for use of DOAC and should be kept on oral anticoagulation include people with antiphospholipid antibody syndrome and people who are pregnant or breastfeeding where DOAC is a contraindication. So there have been a few studies in people with antiphospholipid antibody syndrome in general, not in particular related to CVT, that have compared use of DOACs versus vitamin K antagonists. These studies either completed or were stopped early, and they found an excess of arterial thromboembolic events in the antiphospholipid antibody patients who were receiving DOAC. So in these patients, warfarin is the way to go. In terms of what you do if you're considering a patient who might have antiphospholipid antibody syndrome, you know, what we say is it's worthwhile doing testing for antiphospholipid antibodies in all patients who come in with cerebral venous thrombosis who don't have an obvious like traumatic precipitant or something like that. Basically, it's because that this is something that could potentially change your longer-term management. However, antiphospholipid antibody syndrome resulting in CVT is rare, and it's appropriate just to default to vitamin K antagonists only if you have a patient where you have a high index of clinical suspicion. There are new guidelines for the diagnosis of antiphospholipid antibody syndrome, and in general, we would say you don't need to wait for the antiphospholipid antibodies to come back if you want to start a patient on DOAC. It's just in those patients where you have a high index of clinical suspicion that you should make that distinction. So in terms of how long you anticoagulate people for, you know, in general, we think about people who are lower risk as people who have had a major transient risk factor like cerebral venous thrombosis in the context of the birth control pill or in the early postpartum period. Those patients, you can trend towards a lower period of time on oral anticoagulation. In patients that don't have a permanent indication for anticoagulation, you may want to think about a slightly longer duration. But this is a conversation that is appropriate to make with your thrombosis colleagues as well, because at some point you're going to need to make that decision as to whether to transition someone into anticoagulation over the longer term. One thing that is recommended in the guidelines is based on new information brought forth by the International Society of Thrombosis and Hemostasis. So basically, they've made a recommendation that in people who have venous thromboembolism where you would be stopping anticoagulation otherwise, that's a good time point to do venous hypercoagulability testing, because that may change your decision about whether or not to continue. And it also gives some information to the patient about whether there were any additional precipitants. recurrence for their event. So it's something that we don't recommend doing up front. Some of these tests like protein CNS and antithrombin can be affected by use of anticoagulation. But when you're at that decision point where you may be stopping anticoagulation, that is an appropriate time point at which to do the hypercoagulability testing, unless you're planning on continuing anticoagulation indefinitely in someone with a high-risk thrombophilia like cancer, antiphospholipid antibody syndrome, or a known high-risk hereditary thromboembolic state. So this just basically summarizes the thrombophilia testing recommendations as discussed. Another thing that often comes up is whether or not recanalization should lead to the contribute to your decision-making around whether or not you should continue anticoagulation. First, just one more piece I wanted to mention is when you're deciding about whether or not to consider long-term continuation of anticoagulation, is to think about the overall risk profile of the patient in terms of their longer-term risk of recurrent venous thromboembolism and how to balance that around bleeding. This is meta-analysis data, basically looking at longer-term studies of people with cerebral venous thrombosis and recurrence. Overall, the rates are about 5% for any recurrent venous thromboembolism in all comers, and about half of that is constituted by cerebral venous thrombosis. But patients who tend to be higher risk in studies include men with unprovoked events, people with at least one-time positive antiphospholipid antibodies, people with a prior venous thromboembolism history, whereas people who tend to be lower risk over that spectrum are people that have no other risk factors identified on hypercoagulability screening and have had venous thromboembolism and CVT diagnosed in the context of like the birth control pill or another transient risk factor like the postpartum period. So again, just a summary of those recommendations to consider the patient risk profile and to do thrombophilia testing in patients. So what about recanalization? So what's interesting is that there's been recent data that shows that even in the first week of anticoagulation, that about 70% of patients have some degree of recanalization, and that there is a benefit in terms of less parenchymal damage in people that have that early recanalization in the context of anticoagulation. What we don't know, however, is whether those benefits really extend to increased recanalization over time. Basically, more studies have shown over time that after the 3-month period, the rates of additional recanalization are fairly low. So there seems to be a surprising amount up front, but the longer you anticoagulate patients past that 3-month mark, you may not get additional gains. And so the question is whether some of the benefits of recanalization that we see in meta-analyses looking at all groups are really due to that upfront early recanalization as opposed to continuing anticoagulation for a long time and getting benefits related to that later recanalization. Overall, the literature as a whole has limitations. You know, a lot of it is retrospective. There's heterogeneous timing of when we do follow-up imaging, but we do know that patients that recanalize have better functional outcomes. They have less recurrence of CVT, and they have a lower risk of chronic headaches. So, you know, certainly I think recanalization is something that is positive, but whether it is something that is truly achieved by a longer duration of anticoagulation in and of itself is unclear. So in terms of kind of recommendations around repeat neuroimaging in general, what we would say is that, you know, even though the role of recanalization is unclear, doing repeat imaging for your patient over time assesses recanalization, and it helps to establish a new baseline in case there are any concerns in the future about, you know, recurrent headache and risks of recurrent venous thromboembolism and cerebral venous thrombosis. Again, we really don't know exactly what the risks are, or sorry, what the benefits are in terms of continuing anticoagulation for the sole purpose of recanalization. And when you're doing repeat imaging, again, to remember that, you know, especially in younger patients, we have to consider the risks of radiation and consider use of MRI over CT. Dural AV fistula is a rare complication of cerebral venous thrombosis. It probably affects, 2 to 5% of patients overall over time. Risk factors include patients who are older, men who have lack of recanalization and transverse and sigmoid involvement. But overall, there's no role for routine follow-up imaging just to exclude a dural AV fistula. So I'm going to turn it over to Aviva now, and thanks very much.
Thank you. And thank you for the invitation to speak today. So I'm very pleased to share my stroke story. I experienced my cerebral venous thrombosis when I was 27 years old as an active and healthy young woman at the time. I remember there were lots of symptoms leading up to my stroke, which in retrospect signaled that something was wrong. I remember being at work experiencing excruciating headaches that weren't relieved with any Tylenol. But at the time, I never thought that these headaches could be something more significant. It was so easy to brush it off as dehydration, a lack of sleep, fatigue, stress, being overworked. The list can go on and on. And when I had a more significant symptom of the cerebral venous thrombosis, I was lucky that I wasn't alone and that I was with my mom, who was able to recognize that something was wrong. I didn't necessarily have some of the more classic or typical signs of stroke. I didn't experience any paralysis or any face drooping, but I was experiencing difficulty speaking and understanding. I remember sitting in front of my laptop computer, not being able to understand the questions my mom was asking. I tried to reassure her, even though she told me she thought I was having a stroke, saying I was dehydrated and I just needed some water and that I would be okay. Fortunately, my mom realized things weren't okay, and she drove me to hospital. I remember speaking with the triage nurse and not being able to understand the questions she was asking me. It was challenging for me to articulate the day I was born, who brought me to the hospital, and where I was geographically. I remember being within the CT machine within minutes, and later that day, I had an MRI done as well. The findings of that imaging showed that I had 2 venous clots, one of which bled. I spent 7 to 10 days in hospital. I don't really remember before I was discharged home. It's interesting to think back and reflect on my recovery journey, because in my mind, I always knew and had this sense of peace that I was going to be okay. My recovery journey began the exact same day as my stroke. I remember trying to work towards rebuilding the deficits I had lost, which were mainly around comprehension, word finding, and communication. In hospital, I remember trying to do my very best on every assessment I completed, trying to perform better than I did on the past. I even tried to memorize and remember the response I needed to have to common questions I was routinely being asked. I was so fortunate to have been selected for an outpatient rehabilitation program in British Columbia at GF Strong. This program was so crucial to my recovery, and it allowed me to begin engaging in my life in a new way. I worked one-on-one with a speech language pathologist, a physiotherapist, an occupational therapist, with a social worker, and a psychologist. They all helped me gain back the independence and some of the autonomy which I had lost as a young adult. I was able to get back to school, choose a new career, and I regained my driver's license as well, or the ability to drive. I also had to learn and practice going out socially, and something that my occupational therapist taught me was the spoon theory. And for those not familiar with it, it is a metaphor that describes the amount of physical or mental energy someone has available for daily tasks and activities. Practicing and using the spoon theory was something I practiced early on in the stages of my recovery, and something I actually still utilize to this day. And for some perspective, each day at the time and the commencement of my rehabilitation, I probably started each day with about 6 spoons, meaning that I could do about 6 to 10 things in a day. And this And what this looked like was going to GF Strong and engaging in 3 to 4 rehabilitation sessions. So that was about 3 to 4 spoons, going to get groceries with my mom after GF Strong, and also engaging in conversation at the dinner table. And that was something that was really challenging at the time, because even if there were only 4 people at the dinner table, there could be 2 conversations going on simultaneously. And by the end of this, but at this time, I found it really challenging to follow 2 conversations at once. At the end of the day, I found myself exhausted and making mistakes with my words, and also experiencing difficulty finding the words to speak. I occasionally became frustrated, exhausted, and depleted, and sometimes worried that I would never be able to live the same quality of life I had before my stroke. But with time, patience, and self-compassion, I continued to practice and gain more spoons every day. By the 7-month mark, post-stroke, I found myself waking up with about 12 to 14 spoons per day. I returned to school part-time. I started to exercise more, and I was able to start spending more time socially, going out with friends. It was challenging to be an active 28-year-old when I still required 12 hours of sleep per night. But today, 5 years later, there are days where I feel my spoons are in abundance. I'm able to run in the morning, work an 8-hour day, walk my dog, and then meet my partner and a group of friends at a loud restaurant for dinner and drinks. There are still days where I only have energy to work, but I learned to be patient, kind, and to practice self-compassion. So something I'd like people who are in the recovery journey to know, and it's a motto I used in the early stages of my recovery and I still use today, and it's only 3 words: sleep is life. It was my rock during the initial stages of my recovery, and I still rely heavily on it. There are days and times where I still sleep 12 hours or when I nap during the day, and I try every day to listen to my body to avoid both overexertion, both physically and mentally. And for all the healthcare providers in the audience, 1, thank you for your research and dedication to supporting patients. And I guess 2, I want to stress the importance of one-on-one rehabilitation. I was so lucky that I had one-on-one support from healthcare providers. And to be honest, I don't think I'd be where I am today without the individual support I received, both physically, mentally, and psychologically. So thank you all.
Thank you, Aviva, for sharing your journey. And I was not familiar with the spoon theory, and I'm going to use it now with my patients. So just to kind of move on here, and just to talk about the post-CVT sequelae that Aviva shared with us that are really important to consider. Overall, individuals do well. 85 to 90% do achieve a MRS of 0 to 2. But there are still outcomes that impact people's daily life, and they're quite common. So in the SECRET study, the majority of patients who were enrolled were functionally independent at baseline, but they still had headache, mood, fatigue, lower scores on quality of life scales, and a quarter of them had abnormal MoCA at baseline. But what you can see in these graphs, so on the left side is the registry and on the right is the trial, that over time, most of these scores improved. So they do improve, but it's very important that you ask about these things when you're seeing your patients and follow-up. So just, all individuals should be assessed for mood, cognition, fatigue, functional impairments, including visual, as we talked about, headache, and rehabilitation needs. And, we want to have individuals who've had lived experience of CVT to be advised what is known regarding their history and post-CVT sequelae. So we want to have patients involved in our guidelines and share what they have experienced and how can we do better supporting them. So just a brief last point about seizures, that most late post-CVT seizures, and what we say late is usually greater than 7 days after onset. If you have one of those seizures, you're at high risk of having ongoing seizures, epilepsy, and usually it's related to a structural lesion such as encephalomalacia from a hemorrhage or a stroke. But these individuals require long-term management with anti-seizure medication because they're just at a higher risk of having epilepsy. So there is some evidence. It just shows this retrospective series that 11% had late seizures. The median was 5 months, and late seizures or acute seizures were actually associated with ICH, subdural decompressive surgery, and 70% with one late seizure went on to have additional seizures. So just to sort of close up, we're almost done here. I hope you've, throughout this session, realized that, the importance of a multidisciplinary approach of all different healthcare providers, the patient, in achieving a good outcome for these patients. And, when I'm managing patients with CVT, I closely work with thrombosis, sometimes obs-gyn, and many other healthcare professionals to support the individual in their journey. So just to end up, I'll pass on to Thalia, the last few slides.
Thanks. So I just want to have a few things to mention in terms of special circumstances with relation to cerebral venous thrombosis. We know that women with cerebral venous thrombosis are the largest group. And in any woman that has had a cerebral venous thrombosis in the past, we would recommend use of low molecular weight heparin for future pregnancies for prophylaxis if they're not continuing on anticoagulation otherwise. Another thing about young women is that they have periods, and anticoagulation can make this worse. It's important to ask about this and to counsel your patients. One thing to keep in mind is that the oral contraceptive, as long as a patient is continuing on anticoagulation, is okay. There have been sub-studies of other trials for venous thromboembolism and DOACs that don't show an increase in risk of venous thromboembolic events in people who are anticoagulated, even if they're on oral contraceptives. However, if you're planning on stopping anticoagulation, the oral contraceptive also has to stop because it is a risk factor for a recurrent event. Another thing to keep in mind is that even after you stop the oral contraceptives, that the procoagulant effect continues for about 3 months. So it's important to think about that in terms of timing. Working with your thrombosis colleagues and gynecology colleagues can help to mitigate any complications related to heavy menstrual bleeding and to figure out an appropriate plan for your patient. With regards to trauma-associated cerebral venous thrombosis, this is something that really there is not a whole lot of evidence, and we tend to take a watchful waiting approach kind of as a country, I find, for stroke experts. Patients where you may want to consider what the risk-benefit balance is, especially in starting anticoagulation in someone who may have other injuries. And again, I would stress that this is something that you make as a multidisciplinary decision. Things that might tweak me more towards using anticoagulation as opposed to a watchful waiting approach in this group are people that have obvious extension of the clot on follow-up imaging, people who are symptomatic from the CVT in and of itself, and people who seem to be involving parenchymal damage that is related to the CVT, as opposed to the head injury in and of itself. The last thing I'll say is that occasionally you'll have a patient who has a scan and you just happen to find a cerebral venous thrombosis. Based on we know from the other incidental venous thromboembolism literature, these patients seem to be at similar risk for recurrence as people with symptomatic events. So it's important that these patients get referred to thrombosis and to figure out an appropriate plan, and also that you have these patients checked out by ophthalmology as well. In terms of whether or not you anticoagulate these patients off the bat, it will depend on their overall risk factor profile, and again, in conjunction with your thrombosis colleagues. So that's what's driving those recommendations as they are written. So just to summarize, first of all, I just want to thank everybody, all the experts around the country, including the people with living experience who have contributed to the creation of these guidelines. I'm so proud that we're able to take a focus on patient-centered outcomes as an important part of guidelines that I really don't think have been addressed before systematically in terms of what we do with cerebral venous thrombosis. And I can see some people with living experience whose names I recognize on the list today for attendees, and I thank you very much. much. So again, just to recap, low molecular weight heparin is our preferred initial anticoagulant agent. We want patients to be routinely seen by ophthalmology to follow their vision. The role of routine endovascular therapy is not indicated, and how endovascular therapy fits into things and what we actually do is still something that is evolving. DOACs in many patients are a suitable alternative to warfarin for primary anticoagulation, but not in patients who have antiphospholipid antibody syndrome and not in patients who are pregnant or breastfeeding. We treat patients for 3 to 12 months with anticoagulation in the primary phase overall. How recanalization factors into that over the longer term is not entirely clear. And we do recommend hypercoagulability testing in all individuals who will not be continuing their anticoagulation. It's important to counsel patients and to follow them up with regards to the sequelae that people can experience after cerebral venous thrombosis, headache, mood, fatigue, cognitive issues, and issues with quality of life, as well as for follow-up with regards to epilepsy, and also to consider and counsel your patients regarding heavy menstrual bleeding related to anticoagulation. So thank you.
Thank you very much to all three of our amazing speakers today. That was a wealth of knowledge. We just have a couple minutes left, so there's a couple key questions I want to try to get in before we wrap up. So the first one is, the biggest challenge and what we hear the most, and throughout the guideline development we kept hearing, is missing this diagnosis in the emergency department or in family medicine. And how some of the symptoms present as ischemic stroke, just like with an acute ischemic arterial stroke. What is your best advice in 1 minute or less for each of you in terms of recognition and, Aviva, from your perspective, making sure you're heard when something's not right? So Jennifer, I'll start with you.
Yeah, so I think it's really important, as I said, to, any headaches that are different, new, severe, often it's like, oh, it's their bad migraine. But, in a female who's on the birth control pill, often what will happen is like, oh, it could be a dissection, and then they find the CVT, because sometimes it's hard to know based on symptoms what it is. So I think it's really important, any sort of new, and to be aware of this diagnosis. It's still a challenging diagnosis, but I think, as Aviva was saying, like these new headaches that are different, not to sort of pass off that it's not something severe. So having a high degree of suspicion, and then continuing to educate healthcare practitioners. And then anybody who has any focal neurologic symptoms, I think there was a question in the Q&A that said, how can you tell that this is not arterial versus venous? Sometimes you can't until you get the imaging. So, there's a lot of vascular imaging we do now. And even if it's a CTA, you can still make this diagnosis, even though it's weighted towards more of the arteries.
And Thalia, a little bit of a twist on this then for you is, I think the biggest challenges are outside of the comprehensive stroke centers, where you have more trained and knowledgeable emergency department and neurology staff on hand. What is your advice to the smaller centers that are going to struggle more with this?
Yeah, I would say, I'm a super specialist, and I don't envy the role of generalists who see people with undifferentiated symptoms on the front line. I appreciate that it's difficult, but it's important to know about this diagnosis and to have awareness of it in order to consider it on the differential, because if you're thinking about it, then after that frontline non-contrast CT is done, you're going to think about going to a contrast-enhanced CT to look at the veins and the arteries. If you're not considering the diagnosis and you get a reply back that the scan is normal, then you think your work is done. The other thing to think about is when someone comes in and they tell you, look, this is really different from my normal headaches. I have a migraine, but this is not someone who is coming into the emergency room routinely for migraine management, to listen to them and to pause and to think. And also, there's always, it's impossible to be an expert on everything. And at comprehensive stroke centers, we always have experts who are available for telestroke and other consultation. And, there will be patients, no one is perfect, who will come in as their symptoms worsen. Things can, evolve over time, and just to keep that in mind. But again, knowing about the diagnosis is the best way to work it up.
And I'd say like new papilledema or optic disc swelling, to consider this diagnosis with headache.
No, that's great, great guidance, because I think that's where the biggest struggle is once we know about the diagnosis, then we go into a strong management plan, but it's getting to that diagnosis in the first place, which seems to be the biggest challenge. Aviva, last word from you, and then we'll do a wrap up. What would you like to share in terms of ensuring that people's symptoms get recognized?
Yeah, I think that people who I've spoken to with lived experience as well as myself, you feel something is different than your kind of typical baseline, and just to advocate for yourself if you are experiencing that.
And especially as young women who, at times can be not taken seriously or quickly jump to other potential differential diagnoses, it's really important to push back. And it's okay. It's okay. Sometimes we have to give women permission, or anybody permission, to say, you know what, this really isn't normal for me. Like, there really is something different. And it's okay to push back. You don't have to just accept, if you know yourself, trust your intuition at times, and be vocal. That is okay. And we shouldn't have to give permission, but sometimes it feels like we do. So that's actually all the time we have. We're incredibly grateful to our three presenters. We're also very grateful, as Thalia and Jen mentioned, to the whole writing group that helped bring the CVT guidelines to life. They are currently live on the Canadian Journal of Neurological Sciences, and within hopefully the next 48 hours, we'll be sending out an announcement, and they will be live on the Stroke Best Practice website. So do go and check them out and read all the details, and that would be great. And we will be sending out notice for that, as well as the links when we send out the evaluation. So please do fill out the evaluation. That helps us with future webinars, and the recordings will be available next week. So thank you all. This is the end of our series for now. We'll be taking a bit of a summer break, so we're eternally grateful to everybody and wish you all a wonderful summer. And here's some additional places to reach out, both for professionals and for people with lived experience, if you're trying to connect. So thank you all.
Thanks. Bye.